Hello, everyone, and welcome to Emerging Policy Opportunities for Community-Based Serious Illness Care. My name is Carmel Shachar, and I am the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard Law School, Executive Director. This event is one of the many events put on by the Project on Advanced Care and Health Policy, which is a collaboration between the Petrie-Flom Center and the Coalition to Transform Advanced Care, or CTAC, which is a nonpartisan, nonprofit alliance of over 150 national organizations dedicated to being a catalyst to change the health delivery system, empower consumers, enhance provider capacity, and improve public and private policies in advanced illness care. I can think of no better topic for this project to tackle than a conversation around bringing advanced care into the home and the state leadership that can get us there. Before we start the substance, however, a few housekeeping notes. We have two panels today. Each panel will feature a Q&A at the end, and we strongly encourage and look forward to any questions you may have for our panelists. We ask that you submit those questions at any time during the panel using the Q&A feature found in the meeting controls at the bottom of your screen. So this is the Zoom Q&A feature. You're also welcome to join the conversation or submit questions on Twitter. We are at Petrie-Flom, and you can use the hashtag advanced care. Again, that's hashtag advanced care. If you have technical issues, and I sure hope you don't, please email petrie-flom at law.harvard.edu. Again, that's petrie-flom at law.harvard.edu. We will be sharing the fully captioned event video. It'll probably take us about 1 to 2 weeks to finalize the captioning, and there will be an email sent out to all registrants letting you know the video went live. Please feel free to relive this amazing event by watching the video or send it around to your friends and colleagues. If you like this event and are interested in knowing a little bit more about the Petrie-Flom Center, please sign up for our newsletter. It comes out only twice a month, so not too onerous for your inbox. Please read our blog, The Bill of Health, which tries to bring you cutting edge, really thoughtful health law, health policy, bioethics scholarship about current events in a way that is more accessible than perhaps some academic writing. Or check out our upcoming events. So for example, first week of May, we have two fantastic events. One is looking at medical justice in the carceral state, thinking through who does the medical decision-making, whether it's physicians, lawyers, or prison administrators, as well as a conversation about allocating scarce medical resources. What are the equity and justice concerns, especially in light of what we experienced with the COVID-19 pandemic? We also have events coming up on the science of addiction, considering the needs of vulnerables in the next stage of the pandemic, as well as our annual conference looking at digital diagnostics and therapeutics in the home, which I think may be relevant for this topic. I also want to do a strong plug for CTAC's wonderful events and programming. Please check them out at their website, www.thectac.org, and find them on Twitter at CTAC.org, as well as on Facebook. With that, I want to turn it over to Cheryl Mathis, who is the Senior Fellow in Advanced Care and Health Policy. She's really the bridge between the Petrie-Flom Center and CTAC. In her day job, however, she is the strategic advisor with CTAC. Cheryl, the floor is yours.
Thank you, Carmel. We're really excited today to bring together in one forum some of the top experts in this field. We're going to hear from people working on the cutting edge of Medicaid innovation, making progress in bringing serious illness care to people who have real needs and few resources to address them. Our first panel sets the stage with key federal and state actors telling us why Medicaid, and why now? We have remarks from a top federal Medicaid official, Aditi Malik, from Anastasia Dodson, who is a key California administrator with experience in this area, Wendy Fox-Grage from the National Academy of State Health Policy, who's going to give us the overall picture across the states, and Hope Glassberg, an expert in both federal and state health programs, who is currently working on several initiatives. Let me introduce the moderator of this panel, Dr. Zuri Song, MD and PhD, Professor of Healthcare Policy at the Harvard Medical School. Dr. Song?
Thank you very much, Cheryl. It's an honor to be here and wonderful to join our esteemed panelists in this important discussion. Let me preserve as much time as possible for our substantive content experts and just give a very quick overview of the substantive discussion. As many of you know, the pandemic accelerated the movement of care from within the walls of traditional delivery facilities in healthcare towards the home and the community. And yet at the same time, we live in a world with many inequities, such that care at home remains accessible to some, but not others. However, Medicaid, our federal and state program for many low-income and vulnerable communities, has the potential to address various equity issues through either waivers or plan amendments or other innovations that may allow substitution of lower cost to higher value services, especially those in the home and community, for higher priced or more expensive services that may deliver not as much value in our traditional healthcare contexts, all the while keeping within the budget that Medicaid programs have. Our experts today will address all of these issues, spanning from the unmet need to the unwanted services and the higher value services in the home and community, as well as how to redirect resources towards improved equity, especially pertaining to serious illness for disadvantaged populations. So let me first turn it to Dr. Aditi Malik, who is the Chief Medical Officer of our Federal Medicaid Agency Office and the Children's Health Insurance Program. Dr. Malik is also a practicing physician and is an expert in both the private and public sectors on this issue. So Dr. Malik, thank you so much for joining us. The floor is yours.
Thank you so much. Thank you, Zuri. Thank you to the organizers of this, and thank you all for joining. I am thrilled to be able to be here and share with you all some of our proactive policy priorities related to community-based or home and community-based services, coverage and access, and health equity that I think all of which relate so clearly and so strongly to the goals of this conversation around community-based serious illness and palliative care. If you'll indulge me, I'd like to take a few minutes to talk about some of our proactive policy priorities and then get into some specifics about home and community-based services, as well as our relationship with states and really some of where the policy authorities are and where I think the opportunities are moving forward. First, starting with those proactive policy priorities, we are really focused on three major areas. One, coverage and access. Two, health equity. And three, innovation and whole person care. And coverage and access specifically, that includes broader access to home and community-based services. So making it easier for people to enroll in Medicaid and CHIP, or for those that are dually eligible, and for folks to keep their coverage, particularly as we look ahead to the unwinding of the public health emergency. Medicaid, as I'm sure many of you know, is the primary payer for home and community-based services in the US, and we keenly understand the challenges that enrollees face in seeking home and community-based services. And we are really committed to broadening the access to those services. I'll talk in a little bit about some of the flexibilities of an additional funding afforded by the American Rescue Plan Act, but also other opportunities through existing Medicaid authorities. We also recently issued an RFI on comprehensive access in the Medicaid and CHIP programs. And thank you to anyone on the phone that responded to that RFI, but that will really help inform our understanding of the challenges and better inform our understanding of where the opportunities are with respect to home and community-based services. So I hope that this is really part of an ongoing dialogue around those issues. Secondly, I mentioned health equity, and that for us really includes health-related social needs as well as investments to reduce gaps in care for different racial and ethnic minority groups, as well as other historically marginalized populations. We think about that in a couple different ways, including foundationally measuring disparities and building the data infrastructure to better understand where those inequities are. So for folks alluded to at the outset of this, right, that all too often home and community-based services are accessible to a subset of individuals, not a broader set of people. And we want to understand who is getting those services and where the disparities are in them. Additionally, supporting innovation and adoption of best practices, including addressing social determinants of health and orienting our quality and funding and oversight activities to really close those gaps across 1115 demonstration authority, for folks that speak the language of Medicaid, across home and community-based services, waivers, managed care contracts, approvals, and state plan services. And lastly, on the innovation and whole person care front, what I'd say there is there's a real opportunity to institute delivery system reforms and move towards value-based care where appropriate, with respect to serious illness care. A couple reflections, I think, specific to home and community-based services, recognizing that set of priorities. I will say there are a few topics that touch on all three of those priorities, quite like home and community-based services. We know that people with advanced illness and most older adults strongly prefer to live in the community, and HCBS are a really powerful way for states to help decrease reliance on institutions and make this a reality for millions of Medicaid beneficiaries and dually eligible beneficiaries. So HCBS, including enhancing rebalancing reforms and strengthening access, are things that we all get very excited about, because this is really where care transformation happens. So thank you to all of you that are on the front lines of doing that as well. And I will just reiterate our commitment to the tenets of the home and community-based services settings rule. For those that are aware of what that is the regulatory criteria that really provide the framework for ensuring that home and community-based services are actually person-centered and facilitate autonomy and dignity and independence. I mentioned briefly a moment ago the enhanced federal funding that came with the American Rescue Plan Act. So that provided states with a temporary 10 percentage point increase in federal funding, estimated to be just shy of $13 billion, that offers states a rare and really exciting opportunity to implement changes aimed at addressing workforce shortages, structural issues, the capacity of critical services, constraints on access, and really to begin to meet the needs, not just of individuals that are receiving those services for serious illness care, but also caregivers and caretakers as well. I will refer folks, and I'm happy to put it in the chat or share it with the organizers, to a one-stop shop that we have on Medicaid.gov that makes this accessible, different states' spending plans that they submitted as part of the American Rescue Plan Act, Section 9817, which is the section that authorized this enhanced funding. I will share for one great example of leveraging that funding for serious illness care. So the state of Massachusetts has in their spending plan startup costs to take the POST form and make it electronic and portable to promote access, individuals' access to the treatment preferences and really help reduce unwanted and unnecessary acute and institutionalized care, and essentially using that enhanced HCBS funding to really promote the ability of individuals to live where they choose in their final months and years of life. I'll take a few more minutes on to just mention Money Follows the Person, yet another initiative that we get quite excited about. It's a demonstration program that some states are already participating in, and then we just announced a notice of funding opportunity that is actually open right now until the middle to end of May, that makes individual awards to states of up to $5 million to establish partnerships, recruit HCBS providers, engage in planning activities, and as well as some enhanced funding for states already participating in the Money Follows the Person that support individuals' transitions from institutional setting to the community setting, whether in the context of advanced illness, palliative care, or otherwise. In the interest of time, I will just say lots of other opportunities to address serious illness and palliative care through other Medicaid authorities that I'm happy to get into in the Q&A if folks are interested. Opportunities including through the 1115 demonstration space, as well as state plan opportunities, in addition to some of the waiver activities that I mentioned. And I will just close by saying, working together, learning from each other across states, with federal government, with private sector partners, makes all of us better, and it makes Medicaid better. So I will just reiterate on behalf of, certainly on behalf of CNCS and on behalf of the agency, our commitment to strengthen communication and partnership across the various stakeholders that are represented on the phone. And in many ways, the remote work environment has really allowed us to do that. For folks that don't know, I came most recently from state government prior to this role. I am a hospitalist by training. Zuri and I actually trained together and have worked in the private sector. So I understand the value of switching seats and understanding this issue from a lot of different perspectives. So lots to do, all of which will require good communication, close partnership, resources, and investment. But I am here to say I'm excited to do that with all of you and excited to be in this conversation. So Zuri, I will hand it back to you. Thanks.
Thank you so much, Aditi. That was incredibly insightful. We actually in the agenda have a few minutes for a couple of follow-up questions for you, which in some ways I had prepared. So if you wouldn't mind, I will present those to you and you can take them as you see fit. The first is about working within a budget. Unlike the traditional Medicare program, for example, or any program where we could deficit spend, every state Medicaid program has important and difficult decisions sometimes about redistribution or reallocation within a fixed budget. So how do you foresee the issue of rebalancing or reorganizing funding priorities between a bucket like LTSS, between traditional preventive care and our existing healthcare infrastructure, and HCBS? What sorts of trade-offs or important considerations do you think about in that sort of reallocation? I'll wait for you first before I present the second question.
Yes, it's a perennial challenge of balanced budgets that the federal government also doesn't necessarily have to do, as you said, with the Medicare program or elsewhere. I'm keenly aware of the fiscal constraints and the competing priorities. What I would say is, to the extent possible, we are trying to be as outcomes-based here as we can. And understanding in the construct of priorities that we articulated of coverage and access, health equity, and innovation in whole person care, the set of services that we know to be or have strong hypotheses to be really driving towards better health outcomes and value in those areas. You mentioned traditional preventive care. I think the last thing we want is to see increase in services, right? Particularly preventative services or services core to the Medicaid program. So I would say the way we think about that is it is a perennial discussion of priorities in the context of the priorities that I outlined, but also recognizing that there are certain constraints, like you cannot cut core elements of the Medicaid program. And I will just say, I'll close by saying we are, again, keenly aware of those on the federal side and thinking through what policy levers we have to be able to help support states in overcoming, potential fiscal cliffs related to being able to expand coverage or provide really critical services. And I hear folks are telling me there's an issue with my sound, so I'm just going to mute for a second and adjust my headphones.
Great, thank you. I think we can make out what you're saying. It's a little bit challenging with some background, but I could understand you.
Is that better?
Yes, much better.
Okay, wonderful.
Thank you.
Sure.
All right, let me offer you my second question, which is in the presence of 1115 waivers and different state priorities and preferences, how do you see the role of the federal agency in coordinating between state efforts? And to what extent would you prefer to see states adopting a common approach versus allowing them to have a specific local approach towards the HCBS context?
Yeah, great question. I will say yes, and is the short answer, right? So to the extent that there are evidence-based best practices around assisting, for example, assisting individuals in transitions from institutional settings to community-based settings, and the set of supports that we know need to come along with that, I think many of us would agree that there are a core set of services associated with that that can and should be lifted up as best practices consistently across states. Now that said, you know the old adage of you've seen one Medicaid program, you've seen one Medicaid program. And so there has to be room and flexibility to account for the needs of different populations, regional variations in provider availability, regional variations in service availability, urban versus rural, demographics of a population, that states and their local partners are always going to be better situated to understand the dynamics of that and unique challenges, for example, of interacting with a state legislature or budgetary constraints that are not necessarily replicated across different states and territories and necessitate a kind of tailored approach. So what I would say is we are absolutely thinking about it from the federal level of where are there consistent best practices, and that's what things like the HCBS spending plans have sort of narrative themes and categories to them. So too does Money Follow the Person have like sets of supplemental services that are covered and eligible of late for increased federal match. But the way those take shape in any given state will always look a little bit different.
Got it. Thank you so much. That makes a lot of sense. Given that we're ahead of schedule by a few minutes, let me actually turn to a question in the audience regarding the program Money Follows the Person by Jennifer Ballantine. I hope I've got your last name correctly pronounced. So I'll read Jennifer's question, and then perhaps Aditi, you could offer an answer if you would like, and we can also circle back to our other experts on the panel on the same question afterwards. So the question is, does the program include or include funding support or support the needs of the family caregivers who are often in the position of having to try to replicate the skills and services of facility-based care in the home without prior training or resources?
There is flexibility to be able to do that. So briefly, Money Follows the Person is a demonstration program that was first authorized in, yes, consumer directed. That was first authorized in 2005. And then we just announced, and I'm happy to share the press release. There were, forgive me, I don't know offhand the exact number of states. I think it was initially 20 grantee states that have been given funding to do things like planning activities, establish partnerships, including that could include at the state's discretion, training or engagement for family or other paid caregivers or caretakers in the home to be able to deliver those services. And then, as I said, I'll share the recent press release, but there's actually an additional $110 million out right now in this notice of funding opportunity for an additional 20 states to be able to participate in that program. And that money can go towards exactly this sort of thing. However, again, at a state's discretion, however they choose to expend those funds.
Wonderful. Thank you so much, Aditi. We really appreciate it. At this point, let me turn to our next expert on the panel, who is Anastasia Dodson. And as Cheryl mentioned earlier, Anastasia is from the state of California. She is the Deputy Director of the California Department of Healthcare Services. And Anastasia has lots of experience and expertise in the state's effort in analogous to what Aditi just talked about in our common approach towards home and community-based care for those with serious illness. Anastasia, would you mind giving us an overview, your thoughts on why states are using legislation or how are they approaching this?
Sure, and thanks so much for having me. In California, we have quite a number of initiatives in this area. So I'm mostly going to be talking about our SB 1004, which is the name of legislation that was specifically for a palliative care program. But I don't want to just gloss over the fact that we have used many of the authorities for whole person care, Money Follows the Person, of HCBS spending plan. We have all of that going on as well. But in particular, for palliative care, the state legislature was interested in, for our Medi-Cal only population, how can we advance palliative care for that population? I think there's great interest, of course, for dual eligibles as well, but the purview of the state as far as palliative care on Medi-Cal would be for the Medi-Cal only folks. And so a bill was enacted, and it directed the department, and it was not super prescriptive. It just said, stand up a palliative care program for the Medi-Cal managed care plans. And most of our beneficiaries, even at that time, were enrolled in Medicaid managed care. And so that's the primary delivery system that we have used to establish a palliative care program in Medi-Cal, which is California's Medicaid program. So as we worked through the logistics of that, we realized that there are a lot of questions that, there isn't sort of a pre-printed SPA template or anything like that for palliative care. And in fact, there is a lot of work that continues to be done in the provider community and in the patient community, patient education, about what is palliative care. It's not the same as hospice. And those broader conversations that are happening, irrespective of the payer, Medicare, Medicaid, what have you. But what we tried to do was consult with experts, leverage the resources from foundations, and come up with some definitions that we could all agree on as far as what's a good way of giving some criteria that people, frankly, physicians can use to kind of screen people to say who's an appropriate candidate for a referral to a home and community-based palliative care program. Because of course, many hospitals have palliative care programs as well, but the intent here was to have a community-based sort of outpatient program. I mean, following the person as to meet their needs. So we put criteria together, clinical criteria, very specific clinical criteria. Normally, we wouldn't have such a level of specificity for certain types of services or benefits, but in this case we did, and we chose some specific conditions, and we have a specific package of benefits, and they are all existing benefits. And so what we tried to really message out is we actually there is existing authority in our Medicaid program to assemble a set of benefits that providers can use, and it's really those Medi-Cal, Medicaid managed care plans that need to partner with those providers to make sure that they're providing the right array of services, and again, in line with the clinical criteria. And we did give some flexibility to our Medicaid managed care plans. If they had alternate clinical criteria, that's fine. We just want to know what it is so that we can try to get the messaging out and not get too hung up on, is this person eligible? Is that person eligible? Just try to really just keep building that patient education and provider education and training about, what is palliative care? How is it appropriate? And how does it, align with patient preferences? And I think, again, the broader topic is, that patient and provider education. So I'll stop there as far as our policy.
Thank you very much, Anastasia. And would you mind commenting a bit further about the plan's role? How do the insurers see their role in collaborating with the state agency?
Right. So we have a number of Medicaid managed care plans throughout the state, and we have regular convenings with them. We give them direction, and then we also give them, a certain degree of flexibility because they maintain their own networks. We have network requirements broadly for the Medicaid program. We don't have specific network requirements around palliative care, but many of those same network providers are the same ones who would be providing palliative care. But on the other hand, I'll say that the plans most often then would contract with sometimes home health or hospice agencies to partner, and those agencies have physicians on staff, but more often it's a partnership with the ongoing primary care provider or the specialist who's seeing that patient. And then the plans, they may make some kind of financial arrangement with the provider, the hospice or home health agency, some combination there that can be based on outcomes, patient satisfaction, or any alternative. So we didn't provide a real rigid structure there. And one thing though is that because we have a number of health plans, there's a great opportunity for learning among those plans, because there's there could be local conditions that are different. Los Angeles is certainly different than rural Northern California, and even within Los Angeles there could be different strategies for different populations as well there. So certainly reflecting the different languages, and having culturally competent providers is all part of the responsibility of the managed care plans to make sure that they're meeting the needs of the patients. And I'll say one more thing as far as the financing. So we looked very much at the literature that has been done. There's quite a body of literature on palliative care, and it shows that when it's done effectively, there's at the very least it's cost neutral across, and that's where it's challenging for us with dual eligibles, but for Medicaid only folks, it should be cost neutral at the very least, as far as the state's perspective. So we didn't increase capitation to our Medicaid managed care plans because they should be able to do this within their existing rates. But it does require a paradigm shift in many ways, and so that's what we encouraged. And then back to the technical assistance and the support from the foundations to really promote that technical assistance, because this is not a tool set that is normally sort of mainstream medicine. Of course there are opportunities in medical school for providers, but sort of the overall model is not something that, again, is sort of like just off the shelf, not as common yet as we would like.
Thank you, Anastasia. Similar to our portion with the DT, I'll ask you a second prepared question and then return to a couple of questions in the chat. The second question is, how do you see the role of philanthropy in both implementing and supporting the ongoing sustainability of a palliative care benefit within Medicaid?
Yeah, we really have wonderful philanthropic partners in California, and particularly the California Healthcare Foundation. They were very instrumental in getting the learning collaborative type of effort up and even maintaining it so that we can have variety of folks from public hospitals, health plans, providers, and then speaking with experts. Some of it, again, it's hard to get in like sort of a little snapshot. So there were all day convenings that I think were very helpful for people, because again, palliative care is a paradigm shift, and both on the frontline piece and even on the back end as far as the overall structure of the program. So we very much appreciate the support from philanthropic partners, and they we wouldn't really be where we are today without them.
Thank you, appreciate it. And let me turn to Ellen's question in the chat, and then after that, go to Kate's question in the chat. So Ellen says, how did California navigate the independent determination of eligibility for specific palliative care services? Would you mind commenting on that process?
Sure. So we tried to, and our policy is certainly posted online. We tried to say there is clinical criteria, and of course the patient has to agree to participate. And then in addition to the specific clinical criteria, there's general criteria, and that they, again, they don't necessarily, we try to emphasize this is not the same as hospice. It's not, you're not sort of disenrolling from your regular care team per se, but as we have that approach, and the managed care plans, they can provide an alternative And again, it's cost neutral to the state. So if they want to provide an alternative, based on the conversations they're having with providers, we're open to that. But we don't want it to be any more restrictive. So I don't know if that exactly answers the question, but we're finding that it's working in the sense that we haven't had, we've had a good amount of enrollment. Of course, probably we'd love it to be more, but considering where everybody's at with their understanding of the program, we think that it's working well enough.
Got it. Thanks so much. And let me now turn to Kate McAvoy's question, which is actually for Dr. Malik. Would you mind commenting on any plans by CMS or the Duals program Duals office to promote the adoption of value-based payment strategies through financial alignment demo or such an opportunity?
Yeah, thanks for the question. Folks may be aware, so CMMI published their strategic refresh last fall, so maybe about 6 months ago. That was really a pause and take stock kind of moment. 10 years into the inception and founding of the Innovation Center with the passage of the Affordable Care Act. And a couple key learnings came out of that. One, the model portfolio was large, complex, overlapping, sometimes confusing, real opportunities to improve equity, to engage a broader swath of providers, and to really orient the model portfolio around what the beneficiary impact is, as opposed to what I think had historically been a largely provider-focused lens. So to the question about specific plans to promote VBP adoption, I would say it's more in the context of that strategy refresh. So a lot of ongoing conversations between folks, certainly in Medicaid and CHIP, alongside colleagues in CMMI and the Duals office to really meet those goals. Specifically, how are states engaged in model design? How can we create the opportunity for states or their MCO or provider partners to really engage in those efforts? And making sure that dually eligible, either partial or full benefit duals are able to participate as beneficiaries in those models. And two other things I'll say in terms of like alignment in general that we're looking at relevant to this conversation is in the context of that strategic refresh, a real focus on bringing more care into the community and making sure that care is more integrated. And integrated means both at the provider level, that there's care coordination and appropriate care management, but to the subject of the question, coordination too financially, to the extent that there may be multi-party liability, as is the case in with dually eligible beneficiaries, to make sure that there's financial alignment there too.
Thank you so much, Aditi. Let me now turn to our next expert on the panel, who is Wendy Fox-Grage. Wendy is the project director at NASHP, which is the state, the National Academy of State Health Policy, National Academy for State Health Policy. Wendy has worked extensively across many different states and has a broad perspective on what different states are doing. And I wanted to tee up Wendy's comments by just asking, Wendy, if you wouldn't mind giving us your thoughts on how states are approaching palliative care within their Medicaid programs. What is the role of HCBS, and how does NASHP assist the various states in those efforts?
Sure. Thanks so much for the question. It is an exciting time of emerging innovations in serious illness care and in community-based palliative care in the states, because there's value, as I think we've been talking about, right? So that's why Medicaid, why now? Because they can improve outcomes. It's all about following people's goals and their wishes and what they want, and reducing unwanted, unnecessary, and costly treatments. So you just heard from Anastasia, and I've learned from her as we've gone along through the years about California's Medicaid managed care, palliative care benefit. And states love to learn from each other too, and model and copy each other. And so, we have Hawaii that is following in the footsteps and creating this type of palliative care benefit. And then we've got another handful of states that are very interested in creating additionally that same similar type of benefit. There are 13 states that have serious illness councils that were actually created in state statute. And I think that that's driving a lot of this as well. So states can create a new benefit like this, and or they can also improve care for people with serious illness through their existing state initiatives. So let's just take value-based purchasing through Medicaid managed care, of which we've talked about a lot, right, already in this call. So for example, state contracts can include really important elements like advanced care planning, patient-centered goals and care, home and community-based services, family caregiver supports, pain and symptom management, pulse forms, and care coordination. And in fact, about half of the states right now have moved to managed care for their Medicaid long-term services and supports populations, and care coordination is a very important element in those programs. But despite all this momentum that we're seeing with states and new funding through ARPA and all of this good stuff, I think we have to fess up and say, you know, palliative care is still underutilized, and home and community-based services, we still have a ways to go in states. Again, with palliative care, you know, most people still don't know what palliative care is or how it's different from hospice services, as Anastasia was saying. And again, I think states can play an important role in educating the public about this kind of care. And so to answer your question about NASHB's work in this area, we have a number of different resources working with states to improve this kind of care for people with serious illness. We've been very fortunate that we've had very generous funding from the John A. Hartford Foundation for the past 4 years. We've created what we call a palliative care hub on our website. It has all kinds of resources for states because, as I said, states love to learn from each other and we love to learn from them. If you go to our website, it's www.nashb, it's nashp.org/palliative care. You'll see all these kinds of resources. NASHB, we're a nonprofit organization. We have offices in Portland, Maine and Washington, D.C. I'm here in D.C. And we provide all kinds of technical assistance and a forum for state health policymakers. Some of the things that you can find that we hope help everyone: we have an interactive map on all kinds of state palliative care budgets and laws that states can craft and use as they see fit. We have a paper specifically on Medicaid managed care and palliative care. For states that do want to create a benefit that's similar to what Anastasia described in California, we have a document on the 7 steps that states can take to create such a benefit. We've got infographics, slide decks, testimonials for state policymakers, and we have a 50-state scan and inventory of all the palliative care programs and policies in the states. We've been really fortunate to partner and to collaborate actually with several of the speakers on this webinar to create all these different resources for state policymakers. And so I really think that that's been key, is having states learn from each other and all of us learn from each other, whether it's actuaries, policymakers, and of course, patients and families, right? And so with that, I want to thank CTAC for holding this event today and for inviting me.
Thank you so much, Wendy. We very much appreciate those comments. We are still right on time. Let me turn to our next expert panelist, who is Hope Glassberg. Hope is the president of HD Consulting, and she has worked with many states and hospitals and provider entities in project management, starting new initiatives, as well as those in the private sector related to what we're talking about today. Her breadth of experience is certainly wide, and I want to give Hope the chance to comment on various issues that we've discussed. For example, how do states make the case for changes like a state plan amendment, and what issues have you come across, Hope, as you've worked with CMS and the states?
Terrific. Thank you so much. And I've already learned so much on this panel, so really excited to be here. I think what strikes me hearing about all of these rich developments in our policy ecosystem, the raw ingredients are all here, right? And a number of states have made progress or already making progress toward expanding services for people with serious illnesses. But a comment that I keep thinking about is what you said, Anastasia, which is that this is a paradigm shift in many instances. And there's a lot of work that precedes even getting to the point where you're making the case to our lovely colleagues like Dr. Malik. And I want to share a little bit of on-the-ground experience about the planning and infrastructure that's needed before you even get into benefit design, implementation, and submitting authority requests to the Medicaid program. I'm currently doing some work with our next moderator, Tori Fields, on the Hawaii serious illness palliative care state plan amendment submission that was referenced. And I think Hawaii is very much an exemplar state for that kind of lead up process, having convened over a long period of time a community stakeholder, an extensive community stakeholder process that I know some of our next panelists will be able to comment on as well, just to make sure that different voices were heard, from advocates to providers to health plans, to make sure that all of the nooks and crannies of implementation challenges were sorted out prior to even designing the benefit. There's another program that we really admire called the Alameda County Care Alliance that has also been convening with philanthropic support a number of stakeholders similar to what I described in Hawaii to come together to think about a value-based payment design for serious illness. This all takes a ton of work, and a big thank you to the philanthropic organizations, many of which are on this call or have supported some of the work we're describing, that support that upfront planning process. The resources that NASHB delivers also tremendously useful. However, every state Medicaid program is a bit of a snowflake, so you still need that intensive on the ground, tailored to the state planning experience. And I think that, in addition to the external engagement, there's also an extensive internal planning process that sometimes needs to take place. We've heard from Dr. Malik about a number of different authorities that may be available to states to support these kinds of initiatives, from an 1115 waiver to a Medicaid health home to HCBS. It often requires quite an extensive internal planning process that's tailored to the state context to think about what problem are we trying to solve, and given all of the programs that are in our world today, what is the best? Do we even need a new program, or do we need to simply change quality metrics or reimbursement or other structures in an existing program? These are some of the kind of front end questions a lot of the states that I talk to think about, and again, it takes time and support. And so I guess one thing that strikes me in my time here that I'd like to put forward is I was really impressed with the mobile crisis planning grants that the Center for Medicaid and CHIP Services put out using American Rescue Plan Act resources. And those monies were really meant to go to states to help them do this kind of upfront work that I'm describing, where philanthropy has often stepped in to kind of complement and support. But I think the more that can be done leveraging federal resources to support the front end of the process, the better we'll all be in seeing these programs through to completion. So those are just a few thoughts that strike me.
Thank you so much, Hope. One question I would love for you to provide your thoughts on, and Wendy as well, if you have the chance, is with regarding to cross-learning collaborations across different states. And so a simple question would be, what are some examples of lessons learned from one state that have been applicable to other states, even if at the outset it doesn't seem that these states are all that similar in their Medicaid programs? Do you have examples like that of cross-state learning?
I do. So I've been fortunate enough that we've had like a learning collaborative among states that have an interest in providing this type of care and creating this kind of benefit. So you're going to hear a lot more in the second panel of the people that we've been working with, but there is sort of a similar process that states have to go through. They have to figure out, who the population is they want to target the benefit toward, what the eligibility is, what services are covered. They've got to figure out kind of the costs behind it and the utilization and how large of a grouping targeted group you're talking about. So as I said, we got kind of the 7 steps document that deal with quality, costs, and I think that that's I think it's a great place for states to start. And then there's uniqueness from there. But I think the beginning part of where you're starting and kind of these kind of key elements are shared among states.
I would agree. And I think, you know, some of the challenges and innovations can be universal. Every state's contending with workforce provider shortages, and there's a lot to be learned there. We know that one of the states that we worked with, Hawaii, I believe, successfully used some of that HCBS money that Dr. Malik was referencing to provide enhanced training to providers around the delivery of palliative care. And we know that once that happened, that type of approach was shared with other states, and they can kind of walk a similar road. So again, I think especially for things like workforce training, the quality metrics, these are key areas NASHP obviously has provided a lot of support around and are highly transferable across states.
Thank you, Wendy and Hope. And Hope, another aspect of your discussion that I found very interesting was around lessons from the front lines. What on the ground might we not anticipate or expect from a policy or evaluative perspective ahead of time? So any other lessons that you've gathered over the years, or any other stories from the front lines that you've seen that you think might be applicable across different state scenarios?
I would say don't underestimate how much training and education individuals are going to need on what is serious illness, what is advanced illness, are those different things? What is palliative care? Is inpatient palliative care different than community-based palliative care? You know, I think from providers, even within a state itself, thinking really broadly about all of the folks that are going to be involved in the implementation of these programs, really ensuring that there's a common language and a level set understanding. That might seem obvious, but I think even again, starting with the concept of who needs palliative care, which itself can be a bit of a philosophical debate and discussion, is an area that just there needs to be a consensus and an understanding among those folks who might be coming to the table with very different understandings.
Got it. Thank you, Hope.
Sure.
And at the urging of some of our audience members, I want to turn back to the Q&A. And we have many wonderful questions here. So I'm going to work from the top and want to also acknowledge the several questions with regard to the website links from NASHP, which I think we and Hope can provide here in the Q&A. Let me go to the first question here. This is from Heather Pelletier from, I can't see the full name of your organization. I apologize, Heather, but let me just read your question. This is for Anastasia. What drove the decision in California of choosing certain diagnoses over creating eligibility criteria based only on the advanced condition status of a beneficiary?
Right. Well, back to what Hope had just mentioned, data. So we looked at sort of retrospectively decedent data to see what were their patterns of hospital and emergency room utilization and diagnosis codes, et cetera. And we found patterns, and this was thanks to, you know, the technical experts that we got from the foundation support, philanthropic support. So looking at that data, we could see pretty clear patterns. And then also just looking at the large body of research that's already out there, heart disease, I'm just looking at, congestive heart failure, chronic obstructive pulmonary disease, advanced cancer, and liver disease. Those were, and we could find and work collaboratively with our clinicians on relatively straightforward criteria within each of those diagnosis groups. And that was, if there could be other populations that would be really valuable to have a palliative care program. Again, the Medicaid managed care plans, they can go ahead and do that. It's just the ones that were like straightforward for, patient, provider, making it very clear that those were the based on data and the most prevalent conditions there.
Thank you, Anastasia. I'd like to next move to a question from Melody Cunningham for Dr. Malik, also relevant to hospice care. And that is, are there plans in place to provide concurrent care for adults as we have for our pediatric patients?
Yeah, it's a good question. So with respect to the hospice benefit specifically, that is an optional benefit. So in Medicaid, for folks that don't know, there's a set of mandatory benefit categories. Hospice is considered an optional benefit that's done at the discretion of the state. According to the latest numbers from the Kaiser Family Foundation, about 46 states, I mean, like the majority of states offer some form of a hospice benefit. The specific question around concurrent services, if I understand it, I am interpreting that question to mean concurrent curative treatment or sort of ongoing treatment for an underlying illness concurrent with hospice benefits. It's actually at the discretion of the state. So in some places, there has to be certification of, generally there has to be some certification of terminal illness, but the specifics of whether concurrent medical care can be delivered with the hospice benefit is also part of that optional set of benefits that the state can choose. I don't know if my colleagues have anything they would want to add to that or specific state experience to speak to that.
Absolutely. Any comments from Anastasia, Wendy, or Hope?
No, I think that, that's important, that back to the patient messaging of, what does concurrent care mean? And I think we have not heard that there was a desire for, hospice concurrent, like we tried to sort of brand it as palliative care, but I think it is, can be confusing, and whatever works best for like how providers are communicating and payers are communicating with each other about it, and then with patients.
The only other thing I was going to add, and I would definitely welcome Dr. Malik making sure I'm stating this correctly, but my understanding is that also under the new Accountable Care Organization REACH model, that there is also a new flexibility being offered to participating providers or participating entities in that program that enables concurrent care to certain beneficiaries under certain circumstances. So I think there's some new flexibility, as I understand it, in that program as well, relevant to the question posed.
I would have to check.
Thank you all. I also want to, in response to Tracy's question, mention that indeed the second panel is also recorded. And finally, we have a question from Ken. It's 1:58, so I'll give all of the panelists a chance to tackle this if they wish, but no obligation here. And that is with regard to Medicare's posture or the federal perspective, and we can start with you, Aditi, but please feel free to defer to our others as well. Regarding third payer or essentially private insurer incentives, or potentially even Medicare incentives for similar palliative care programs outside of the Medicaid population. Any general thoughts on that issue?
Yeah, happy to. I will say to the question about posture or general philosophy. As a general posture or philosophy, we one of our core operating principles as an agency under the leadership of Administrator Brooks LaSure is to really try and align across the 3 M's, which is wonky speak for Medicare, Medicaid, and CHIP, and the marketplace, which are the programs respectively that are regulated by CMS. So we're doing that across a number of areas. I mentioned social determinants of health, quality measurement. Certainly, to the extent that there are opportunities to align either incentives or benefit packages or even messaging and communications around serious illness care and palliative care, certainly would welcome folks' specific suggestions on how to do that. But I will say, as a general posture, and that is a core operating principle for all of us.
I'll just jump in to say we would love to explore this further, but I think, the Medicare landscape is complex as well. Some folks are in original Medicare, some are in Medicare Advantage. That needs to be taken into account. But when we develop the Medi-Cal palliative care approach, providers especially were saying, okay, that's great for Medi-Cal, but what about Medicare? When can we do this for Medicare? And so, and I know it's a very complex and sensitive area, but just to say there's a huge appetite for it.
Thank you, Aditi. Anastasia. And I'll just acknowledge our last comment here 1 minute ago from Kelly Baxter, which is an important perspective to add onto all of the comments you have made. So let me give a round of thanks to Aditi, Anastasia, Wendy, and Hope for offering their expertise and insights for us today It is 2 p.m. here on the East Coast, so I will turn this back to Cheryl. Thank you all again. I really appreciate it.
Thank you, Dr. Song and panelists, for a really informative discussion. My head is spinning. But now we're going to turn to our second panel, who are going to get even more into the details of the how. Our moderator, Tori Fields, has extensive experience working with health plans, other actuaries, she is one, and state officials building palliative care benefits for public and private plans. She has worked closely with the co-panelists, and together they're going to show us how it's done. This panel will delve into the key considerations a state must address as it seeks to build a Medicaid benefit for community-based palliative care services. Tori?
Thank you, Cheryl, and thank you so much for having me today, and to the first panel for setting the stage for the next part of our discussion. As you heard in the first panel, states hold this tension between identifying best practices and taking a common approach to advancing care for people with serious illness, and also identifying the specific regional variations that they need in order to care for their populations specifically. What is needed to walk the line most effectively is what Dr. Malik stated: partnerships, innovation, and collaboration. Luckily, we've been able to gather together experts here in designing and implementing and evaluating programs that care for people with serious illness. The individuals on our second panel are deep in the weeds. They are focused on the details of what makes these programs work and what makes them most effective. They have worked together over time to gather and define the best practices and have the evidence to actually make it a lot easier for states to advance this type of care, both for Medicaid and dual eligible beneficiaries, but also for individuals in the private sector. So I think that a lot of these things that you're going to hear from these panelists actually really does apply outside of Medicaid. And what I like to think is if we're focused on Medicaid, we're actually really able to lift all boats for everyone within the state. I'm going to invite my co-panelists here, Dr. Ray Seitz from Huipohala and Kakuamau, Allison Silvers, the Chief Health Transformation Officer for the Center to Advance Palliative Care, Kathleen Kerr of Transforming Care Partners, and Elric Berkman, Senior Manager, my fellow actuary at Optimus. Dr. Seitz, I'd love to start with you. I know that with palliative care, often we want to start with a patient story and making sure that we are here remembering why we're all really trying to advance this type of care. Can you share a little bit about why Hawaii started this work over 20 years ago, what you were really setting out to achieve, and how Huipohala and Kakuamau have been part of that initiative?
Wow. Well, it's a long history. I'll try to make it really short. But I was a hospitalist working at Kaiser, and what I encountered were people who were chronically in and out of the ER and the hospital dealing with serious illness, and they showed up in crisis, in confusion, and in chaos. And I began a journey to try to figure out why that was. And what I discovered was that I could take care of things in the hospital, tune them up, get them on the right medications, talk to them. But when they left the hospital, there was chaos going on in the community. Their extended caregiver group, their village, needed to be involved in their care, because when a person is ill, their health literacy, their ability to understand things and to remember what to do is really impaired. And so the village around them becomes very, very important. The long story short is that in the early 2000s, we went on to build a home-based palliative care program at Kaiser Permanente. It was one of the early ones in the country, and it showed incredible success. People who were coming in crisis after crisis suddenly had a stabilization of their medical condition. Their quality of life improved. Their families were very much more satisfied and felt better controlled in terms of what was happening. And we found out that it cost less to provide this kind of care for people, which was superior. I then went on to build home-based palliative care for the Blue Cross Blue Shield affiliate, and that now exists statewide. And it continues to be, I think, a very effective program. But we've learned some things about how to keep that going. The journey has been really influenced by the work of Kokuamau, which is a coalition, a collaborative of everybody in the state, really, who has any interest in serious illness care, in palliative care, and in hospice care. I've been a founding board member of Kokuamau for many years, and that is the go-to organization. If you want to know anything about what's going on in the state, that is the go-to organization. A couple of years ago, some of us felt that we needed to have kind of a speedboat type of organization that would really focus on improving access to high-quality palliative care. And as a previous speaker indicated, language is so important. And one of the most challenging hurdles we're facing right now, and we continue to work on, is how do you define palliative care? How do you identify the people who would best benefit from palliative care with an eye towards expanding to interface with people earlier in their trajectory of illness? And so our organization, Hui Pohala, is committed to increasing access to high quality palliative care. And we have we've adopted the CAPC definition of palliative care, and that is what we are striving for. Yeah.
It's really such a great history in terms of what groundwork had been able to be laid even before really getting legislation or leadership at the state level involved, where the role that a coalition actually is able to play is to get everyone on the same page and to make it a lot easier to get implementation actually done. Policy is only as good as how well it's implemented, really. That's and right. So there's that long history there that then can be really used and leveraged at the state level for benefit development. How has your learning changed in terms of thinking about the Medicaid population? Seeing as you really had moved from the commercial health plan development, and now we're looking to advance this on the Medicaid side as well.
Right. You know, I think that what I've learned is, number one, there are a lot of benefits that Medicaid members have if you could figure out how to access them. What I've learned, I think, is that there are what I call linchpin people, entities out there that can really be impactful in terms of understanding what a person wants, needs, aspires to, marrying that with their condition that needs to be managed, and then understanding what benefits can be applied to best help this member and their caregiver village to meet their goals and expectations. There's a lot of things that are still needed and benefit design that needs to be attended to, but we can't forget that there Medicaid has rich benefits. The problem is, how do we enable people to actually understand what those benefits are and apply them appropriately? And for that, we need case managers, we need discharge planners, we need those people at those transition points to become part of a palliative care team, to really understand what value palliative care offers, and then to help make the linkages as a person transitions into different venues.
Absolutely. The need to be able to really assess for what needs people have and route them to the right place.
Yeah. And to do that, you really need people who are skilled in shared decision making, people who are really skilled at being able to probe and understand what makes this person in front of you unique among billions of people on this planet. What makes that person so unique? What are their values, their beliefs? What are their aspirations? And what are the challenges that are preventing them from reaching those aspirations? That kind of communication skill, we need to really work on. And we need to create mechanisms to ensure that people are acquiring those skills and applying them appropriately. And I think that's going to take a shift in how we look at healthcare, because what we need to do is really to invest in people who are taking care of our most complicated and needy folks. We need more of these people, and we need to make sure that they are supported and trained appropriately. We've got to invest more in those types of people.
Absolutely. Thank you for that. It is actually, in hearing from the first panel, some of these ways that these HCBS ARPA funds can be distributed, and also where philanthropy has come into play, I know in the California story as well. Allison Silvers, since we just got on this topic of provider capacity and workforce training, we'd love to turn it over to you to share a bit about the Center to Advance Palliative Care and the goals that it has had in really supporting these efforts, both on the linchpins, as Ray was sharing, and also in the provider capacity to be able to deliver these services.
Yeah, thank you. And I do want to pick up what Ray was saying, that there's a growing evidence base that those linchpins who usually don't sit on palliative care teams, they are the hospital case managers, the health plan case managers, the long-term services and supports coordinators. They're really the ones that, when they have the right skills to clarify goals of care. Another important skill that needs to be taught is helping patients and families understand their disease and what to expect from that disease, because they're making treatment decisions. There have been studies that people with terminal cancer are making treatment decisions thinking it's curative, like the majority. So explaining what's going on is another important skill, as well as clarifying the goals. And as I said, there's now several articles showing that when people have those shared decision-making capabilities and hold those conversations, that it can really make an impact on the trajectory. And that is where the Center to Advance Palliative Care is focusing, trying to get what the right communication skills are and the right assessment skills too, into the hands of the broader healthcare system. Another thing that CAPC has been learning, we've been taking a deep dive into Black Americans living with serious illness. and the disparities in pain assessment and pain treatment from Black to white is really tragic. And part of addressing that would be systematic assessment. If somebody has a certain diagnosis, the symptom assessment should go along, the caregiver burden assessment should go along with that function, and starting to, again, as Ray was saying, starting to get clarity on what should happen next. So if we could get the what we call the usual care system trained in that, I think it would make a tremendous difference.
One of the things that I hear very often is, while there is a definition of palliative care, it is tough to operationalize. In thinking about how we create these benefits, what are your thoughts in terms of those minimum standards or requirements or things that actually need to be included to ensure that we have consistency on teams or consistency in delivering high quality palliative care?
Was that for me?
Yeah.
So there's really just some essentials. What people may know, there's something called the National Consensus Project, Clinical Practice Guidelines for Palliative Care, and they are extensive across multiple domains of need, with various pieces to comprehensive care. And it's a really great touchstone to work from. But in terms of a floor and in terms of the variability in patient and family needs, it's a Venn diagram and it's hard to make it work. So CAPC has been working on some basics, what needs to exist. One of them is it should be multidisciplinary, borrowing from what Anthem did. Anthem used at least 2 disciplines. I think definitely a prescriber should be on the palliative care team to address those symptom burdens. And then, I think if you can add in nursing, social work, chaplaincy as needed, based on what the patient and family need, you can get very far. In terms of the prescriber, remember that palliative care really is a medical specialty. As much as I said, there's some basic skills that can go in the usual care system, but for a specialty palliative care team, the prescriber really has to show demonstrated competency. We recommend that come through board certification or some other professional certification. Another important thing that is in the community for home-based palliative care is 24/7 access to somebody who has the medical record. So it should be somebody who can access what's going on with the patient and also has the skills to meaningfully address their situation, not somebody who will say, oh, thank you for calling, I think you should go to the emergency room now. There are instances where people should go to the emergency room, but the person should be competent in dealing with that and making that assessment. I'm doing this from memory, but I think another core thing is showing competency in the communication skills as well, some sort of demonstrated competency there. And I probably am leaving things out, but those are the top of mind, what a specialty palliative care program should deliver.
Can you share a little bit, Allison, about your thoughts in terms of this tension around capacity? We often hear about there not being enough palliative care specialists, but there is a great need for these services to be available. And it's something that we often run up against in terms of thinking about how to better or more clearly define benefits or create benefits and programs for this population. What efforts can be made there, and how do we think about the capacity versus need issue?
And that's a great question. And I think one of my concerns is that as benefits are being built, and frankly, as they might become richer, in order to manage the overall expense, it means that the population that can access it has to be clearly defined and managed. And I would prefer a vision where the population who can access palliative care is as broad as possible, and maybe the benefits get tiered or dialed up, dialed down, so that access for more people could be there given the capacity limitations. A couple of things on that. I think that the palliative care programs that exist often come out of hospices, at least in the community, I should say, often come out of hospices. And coming from that experience of the hospice benefit, where you're in charge of pretty much everything for the patient, gives you a certain model of care. But as you go further upstream, and to Ray's point in the earlier panel, in some states, I'm in New York, Medicaid has some really rich services and benefits, and you don't have to be all things to all people. You really could just provide that added layer of support, which could be a thin layer of support on top of Medicaid personal care services, on top of Medicare home health care, on top of all those other benefits. So I think part of expanding capacity is adding in the palliative care team and services where to fill the gaps and where it's needed, but maybe not more than that. Another thing is dosing it up and dosing it down based on patient need. And there's one program that I know of that I think the phrase they used was relentlessly disenrolling. So they would bring people on service, like Ray, you were saying, you tune them up and you get them on the right meds and then they're okay. And but in the community, you have the advantage of the tune up involving the community supports and services. And once they get to a stable place, they discharge them, which then creates capacity for new patients to come on. My favorite one that does that disenrollment keeps in touch with people by text and does a text bot. Are you okay? Are you okay? And when someone says, hey, no, I'm not okay, the team gets involved again. So the theme is efficiency, and I do think there's a lot of room for improvement to get the services to be efficient and matching needs, and when needs reduce, then reducing services.
Thank you for that. It's one of the questions that was in the Q&A area was really around the role of telehealth and the role of these tele-based services. And those are areas that are really areas of exploration that can be used to layer in additional support for individuals and their families, especially as we're thinking through how to get more sophisticated in dialing up or dialing down services across the continuum. I'm going to turn it over to Kathleen Kerr, who has spent a fair amount of time actually tracking the utilization of these services through California and other places, and would love to hear from you about your experiences in tracking the SB 1004 implementation and the outcomes from the collaboratives with plans.
Sure. Let me thank you, Tori, and hi, everybody. Kathleen Kerr, healthcare consultant based in California. I've been, for the past number of years, been working with those philanthropic organizations. So the California Healthcare Foundation, as well as a nonprofit collaborative here, the Coalition for Compassionate Care of California, which have both been very involved in implementing the California Medicaid or Medi-Cal palliative care benefit. So Tori, your question about tracking. There has been a slow but steady increase in the use of the benefit within California. Initially, the couple dozen Medi-Cal managed care plans reported their enrollments to the state. And once that stabilized, then that requirement was discontinued. So now the only tracking that's happening in addition to plan level tracking is tracking that's done through a survey that's sponsored by the Coalition for Compassionate Care of California and the California Healthcare Foundation. So through the self-reported information that the plans have shared with us, we've seen slow and steady increases. We've been doing this for long enough now where we can sort of look back in addition to sort of getting a one-year snapshot. And the most recent data where we had 10 of the couple dozen Medi-Cal managed care plans that reported their volumes in 2019 and 2021 for this program, there was a 94% increase in enrollment across that span of years. So it takes, I think that the take home for me is things do ramp up, that some of these issues related to capacity and preparation, the good news is, well, the bad news is not everybody gets this instantly as soon as the benefit is passed, but the good news is you have a little time to grow. And so there'll be a slow ramp up in the number of folks who hear about it, understand it, are enrolled. And so you don't have to have instantaneous capacity to take care of everybody who's likely to benefit from a practical perspective. It just, people don't enroll in it. If you think of the decades that it took for the Medicare hospice benefit to reach half of Medicare decedents, even for a couple of days. This is moving along a little bit faster, but you don't have to have, you won't expect everybody to enroll instantly. So slow and steady increase. The low numbers that enroll initially, I think in particular for a Medicaid benefit, can feel difficult for both the plans and the providers to manage. So part of one of the questions that we ask in an annual survey of the plans and the providers are, what's a threat to sustainability? How's this working for you? Good, great. What might get in the way of continuing with this? On both the plan side and the provider side, low enrollment is viewed as the biggest threat. So if I was to give advice to anybody who's thinking of implementing a benefit in another state, it's really think ahead of time about what you can do to maximize awareness and enrollment so that the benefit that's there gets used by as many people as possible early on. In terms of impacts, there hasn't been a lot of public shared information about, in particular, financial outcomes from the program. I know of several plans that have looked at this independently, and they have seen more than satisfactory results. I think, as Anastasia put it, at least cost neutral. Some have done much better than that. There was a recent demonstration project that was sponsored by the California Healthcare Foundation and led by the Coalition for Compassionate Care of California, where we looked at the performance of the SB 1004 Medi-Cal palliative care benefit and other types of home-based palliative care that was offered. And that showed very positive financial outcomes from the preliminary assessment for the total cost of care decrease, looking at pre versus post a preliminary analysis in the Medicaid population. It was about a 49% reduction in total cost of care. Looking at that level of with that type of analysis, a more rigorous analysis will be published in the coming months. But nothing that we've seen has shown that the reduction in preventable and non-beneficial care is sufficient to keep track with the extra cost of providing services.
So you're saying that we can do this?
I'm saying we can do this. Yeah, I think that the statement that Anastasia made, that there's abundant evidence that, in particular in the way that the population was defined in California, so really aiming at folks who are in the final year of life, that's how it was defined as a minimum standard, that you should be able to deliver palliative care in a way that's at least cost neutral, that the cost of providing those services doesn't exceed the savings by avoiding non-beneficial or preventable care. And that's certainly been the, from all the data that I've seen, the experience that the plans are having. Now, I would say that with the Medicaid population, it has been noticed by some plans also that there's quite a bit of unmet need generally. So what you might see is an initial bump in the cost of care because these folks probably have conditions that haven't been addressed sufficiently. And part of that sort of care coordination function that the palliative care team can play, they recognize that and address it. So it's important to look at these outcomes on a population basis and a longitudinally. But you may see that, oh, you have all these issues that nobody's noticed or attended to yet. Let's take care of those first. So you might see a little bit of elevation in your spend, particularly early on.
I think it's a really great point in terms of tracking back to some of the earlier comments around there being so many benefits available to Medicaid beneficiaries, but if you build them, they don't just come. People don't just know about what is available to them and their benefits, especially Medicaid beneficiaries who may have had less experience interacting with the healthcare system or less experience having insurance overall, and even knowing what is covered. It can be a very disempowering experience. Can you share a little bit about what your thoughts are and what you have learned in terms of how we might go about getting more people engaged in these types of programs, what outreach types of strategies might need to work?
Yeah, that's a great question. Just as you were talking about how difficult it is to navigate the system, we were on a call with the medical director for a palliative care program at a plan said that she actually had trouble figuring out who would pay for what DME. And she's like in the plan. This gets incredibly complicated. And then, so I think that this emphasis on navigation of systems on the plan side and then on the delivery system side as well is super important. There's a couple things that I think can help with increasing enrollment or to making sure that those who would benefit know about the program, understand it, and then it's offered to them and then they're able to accept it. One of the most important ones, I think, in this for the Medicaid benefit in particular is leveraging trust. And so if you have folks who have been shut out from access historically, or where there's any issues with trusting the healthcare system, going to the organizations that have trust and leveraging that trust to help to educate around palliative care can be really useful. So Hope mentioned an organization, the Alameda County Care Alliance. It's a wonderful organization that provides lay navigation support. It's anchored in a hub of Baptist churches. And so they've done an amazing job of educating around advanced care planning and serious illness care and spiritual support, emotional support, all sorts of things. And they are a trusted voice in their community for congregants and others. And partnering with entities like that within a community where you're able to have an introduction to palliative care from somebody whose voice is respected and trusted can be really, really helpful. I think we should never overestimate the extent of the knowledge deficit around what palliative care is in the provider community. So there's a ton of excellent oncologists and cardiologists and primary care physicians, et cetera, who do not know what palliative care is. They conflate it with hospice. They say, oh, my patient's not ready for that. They also may just have fears about giving up. They may not have experience with co-management or may not know the particular entity that's delivering care. There needs to be a ton of education with those folks about palliative care generally, and then about a particular benefit specifically. And it can't be, let's hold a webinar, we'll talk about this for 30 minutes and then expect them to all refer. It needs to be integrated into the workflow and it needs to be anchored in relationships. And so I think that if you keep those two things in mind, integrated in the workflow, make it easy, anchored in relationship, face-to-face interaction or Zoom-to-Zoom interaction about specific patients so that they can see this is the value add of these services, that will promote referrals from those sorts of contacts.
I think that's really a necessary point here in terms of thinking about where people are actually coming for their, or going to for their care, and where they're looking for an extra layer of support. Oftentimes we want to think that it's the health insurance company that people go to for those things. And you know that that's not true, really, for anybody. One of the Q&A questions, I think, can be for anybody on here. One of the questions in the Q&A is around providers not always having the willingness to train non-medical folks in these types of referral efforts. I know at least in the Alameda County Care Alliance initiative, Kaiser played a major role in being a partner with that organization. What other opportunities might there be available for those who are non-medical and actually do want to build up this infrastructure or these types of skills?
Can I start with that? There are growing numbers of doulas, palliative care doulas, that are being added to palliative care teams, community health workers. There's a number of programs that include community health workers. To Kathleen's point, these two types of positions really do help build some trust and education about what palliative care is. And there are, you know, just from the literature, I know of organizations that find people in the community, not uncommonly going to the churches, and trying to find folks who might be interested in being trained for these positions. So one suggestion is Google doula, Google community health worker in your community, and see what you can come up with.
You know, I think that's a really interesting subject to kind of get into. And Huipuhala is looking at what we can do to bring, for example, community health workers. And we've got a number of programs and a bunch of people in our communities who are community health workers. So they're at the bedside, they're supporting people. Can we bring them into the palliative care family? You know, figure out what additional knowledge and skill sets do they need to be able to play their role more effectively. And there's interest growing. We're developing some projects around that. One thing I would like to just kind of drop in here, and that is that the issue of coordination of care. Because that is, to me, one of the most important core elements of any palliative care program. You've got to get the team, and our teams grew out of hospices. Hospices have, in our community, a history of taking over the care of the patient, doing a wonderful job, but doing it internally with their own teams. And so a lot of the other providers sort of fade away into the background. When you have a palliative care patient who is going for life prolongation or even cure of their condition, you've got to figure out a way to interface with those other providers and coordinate care so there's a single page of music that everybody agrees to. That's a really tough nut to crack, because providers get very busy. They don't want to return phone calls. They don't see the value of returning phone calls to the palliative care team. Palliative care team feels disempowered, not sure how they're going to integrate to create a more robust care plan. So we've got to figure out the ways that we can support the growth of those partnerships like Kathleen was talking about. And maybe sometimes it's going to take the plans or somebody with authority saying, you got to do this. Sorry, I know you don't like it, but if you want to play in our sandbox, you're going to have to do some of these things. And then, you know, the softer, this is the value that we bring. It becomes very satisfactory for the providers. It only takes one or two cases for them to be won over to the value of palliative care. But that effort for that one or two cases is pretty big.
Can I just quickly interject? I would just posit that it doesn't always have to be the palliative care team who is responsible for the care coordination. Again, I'm sitting in New York and we have an army of health homes that coordinate typically disease-directed care, behavioral health care, substance abuse care. And for those that need palliative care, they would be added into the orbit, but the health homes would be, they're already coordinating and trying their best to share information. It's not easy. So I just wanted to put that in there.
Yeah, I think you're right. Thanks.
It's a really good point, Allison, and it's one of the reasons why I think there's a need for a state-by-state focus, right? And so you understand what are the resources available in my state, what's happening reliably across markets, and where do we have gaps. And then I really appreciate this point of care coordination is central, but you don't want multiple care coordinators so that it creates duplication of services or confusion or fatigue on the part of the folks you're trying to help. And so it circles back around to this workflows and implementation choices and role clarity, just to, if you have the waiver or the law or whatever that gets you the benefit, excellent. But there's 99 other things you have to do after that's in place to make sure that it's implemented in a way that promotes efficiency and efficacy and coordination. I think one thing I'll add too, Ray, in relation to your comment about community health workers, there have been some lovely experimentation here in California, I'm sure also in New York or around that area. And one of the plans shared that the thing that they've noticed that folks need the most education on is they don't understand health plans. So the Medi-Cal managed care plan is completely new to them. So they need the education around that. And then also they may be a little less experienced in communicating and collaborating with those primary care providers or the oncologist that's serving as the de facto primary care provider. And so helping folks who know the community really well, what the needs are, common language, et cetera, but helping them to get to know the plan and then understand what are the most effective ways to interact with those other providers that are also participating in care can really help to sort of close that loop.
Thank you, Kathleen. One of the things that actually I have been hearing as a major theme in going on this panel so far is really a need for coordination and deduplicating or not duplicating services that are already there. That is, I would say, most definitely something that actuaries and analysts often really focus on, especially when we're thinking about developing value-based payment models or new benefits. Elric, I would love to hear from you around what you and Optimus have found in your analyses to date, really trying to take in all of this information about palliative care and finding what can be coordinated, who needs services, and what is the same across states.
Yeah, thanks, Tori. Hi, I'm Elric Berkman. I'm an actuary and a senior manager with Optimus. We've been working with NASHP to kind of take more of an actuarial approach to costing out a palliative care benefit in Medicaid programs. Now, typically when we go through this process, it's, the actuarial cycle is really defining the problem, designing the solution, monitoring results. We try to leverage as much information that is already out there so that we can kind of mold our solution to fit what has already been done. But essentially what we see when we do this, certainly we don't want to duplicate efforts when there's already care being offered. So it really requires us assessing what's being covered currently and what can be leveraged for new benefits. So it's a lot of in the same vein as what everyone's been talking about here. But when we took this actuarial approach, it was kind of identifying where these members essentially where these members live that could benefit from the palliative care benefit. What we saw is these members that go into hospice, of course, they're going to be higher utilizers prior to going into hospice. There's ample opportunity for savings there. Essentially, what we were trying to demonstrate that was with these higher savings there, it's certainly possible, or what we see is it's going to be cost neutral no matter when the state effectively implements palliative care benefit. So it allows them to provide palliative care services across a broader continuum of the disease stage for these members with serious illness. But of course, there's also factors that are going to vary between states, such as the richness of the palliative care benefit, provider education and network adequacy. That's certainly going to impact uptake of the benefit. And it sounds like Kathleen, you described, rampant's been relatively slow in California. So that's certainly a big piece of it. And then also just levels of reimbursement for Medicaid services across states as well. That's going to vary as well, and so definitely impact what level of cost savings could be achieved. But I think, again, what we're really seeing with the analysis we've done is that it's essentially going to be at its most expensive, cost neutral to the state. There's no reason that states shouldn't be pursuing these benefits.
And where are you seeing the most changes? Where are you estimating changes in terms of cost and savings for this population?
Yeah, and our analysis really focused on savings in the acute care settings, inpatient stays, and then emergency department visits. And we did focus more on the Medicaid only population. Certainly the picture gets a little muddier when you throw in the dual members because of the Medicare coverage there for acute care. But yeah, so we assumed savings on the inpatient stays and then emergency department visits. So that's not to say, and like Kathleen had noted before, that certain other costs wouldn't go up as well as members start to utilize the palliative care benefit. But there's also considerations for areas where additional savings might materialize. This is really the monitor results stage where I'm definitely interested to see some of the preliminary results from the California evaluation of their palliative care benefit.
We hear a lot of times that that palliative care delivered in the community by a team is expensive. But put in context, it sounds like it is less expensive than the alternative.
Absolutely. And to the extent, again, that you can leverage provider networks that are already established, certainly there are specific palliative care providers that might need to be more specific to palliative care, but leveraging what's already there will help at least get some of that education out and eat up some of the cost that's already inherent in the program.
Can you share a little bit about the disease conditions that you were looking at in terms of covering this? I know that California is, as the first one out of the gate, was relatively narrow in defining who would be eligible or appropriate for services. How in your look back or review, how has that changed or stayed the same?
So what we did for our analysis, we did look at prevalence of serious illness within these Medicaid populations, just to get an idea of how many members could potentially need coverage of palliative care services. And we looked at 2018 and 19 data for 3 state Medicaid programs. And we looked at the prevalence of cancer, cardiovascular disease, COPD, kidney failure, liver disease, and neurologic disorders, and found that prevalence across all Medicaid populations for any of these illnesses was between 7% and 10%. So now, when we narrow that down to specific eligibility categories like our disabled populations or the long-term care populations and dual eligible members, that's where we're starting to see much higher levels of prevalence for these illnesses. We are seeing prevalence ranging from 30% to as high as 80%. And so we know there are a lot of members suffering from serious illness in these Medicaid populations, but let me also caveat that this analysis, again, was based on flagging diagnosis codes for each of these serious illnesses. And there are additional considerations that need to be accounted for when determining who should be eligible for a palliative care benefit, such as prognosis and functional health certainly plays a role as well.
It's a huge opportunity for us to look across a lot of different disease types, and also really to take into consideration what Kathleen, you were saying in terms of thinking about being more broad, but understanding that the ramp up can be slower over time.
Yeah, the one thing I'll add is more than 70% of the Medi-Cal managed care plans have increased the eligible population. So they've expanded on those minimum of just the 4 diseases. So it kind of, many of them also have sort of a catch-all category of other individuals with advanced disease. So I think the 4 was a minimum and a starting point, and most have gone well beyond that.
Mm-hmm. One of the questions that came up in the chat from Jennifer Ballantyne is actually asking about if you've seen one palliative care program, you've seen one palliative care program, and how do we actually, now that we're thinking about moving this into more formalized benefits or programs, how can we sort of carry that tension where some of the plans say are expanding their eligibility criteria while others aren't? And some have floor services, but others, as we're hearing here, have added lots of different newfangled things. How do we manage that tension of adding on or adding more, and also still having minimum requirements?
Is that for me?
I would say this is for the group.
I'll just start with health plan credentialing. There should be a process in place if a payer is going to support something, that they should have standards. So I guess if there's a Medicaid plan that doesn't have managed Medicaid, they would have to do it themselves, or they can put out an all plan letter and the state Medicaid agency could define what that is. CAPC took a stab at putting together what we gathered from health plans over the years. It's on our website, probably in the 4th column of resources under defining quality. So those are there for folks if they want to start there. But there's also, obviously, in California, the states have come up with their own credentialing, and those would be resources as well.
You know, Tori, it's a really interesting question. And I don't know how common it is across other healthcare sectors. I was thinking about that. But I think it's quite possible to offer general education about palliative care as one form of serious illness care. And then there's plan-specific eligibility criteria, specific services. I think that we're kind of used to that there's different, like you can get things from one plan that you can't get from another plan, or that sort of thing. So I think emphasizing both bits. This is what palliative care is generally, and this very specific thing, which is SB 1004 palliative care in California, this is how that's framed. And I think as long as you make it easy to make a referral and sort of clear about generally who is eligible and have alternatives ready, even if they're not eligible for that particular benefit, then, and that's also quite similar to how it worked in the hospital, right? When we were all building inpatient palliative care services, it's like, refer to palliative care, even if we can't help you, we'll get you hooked up with the right one. I think early on, when there was fears about use of that sort of service, that was a perspective that folks used. And I think it gets to this care coordination, non-duplication of benefits, not exploding the palliative care benefit to cover things that are already covered in other parts of the Medicaid programs. I think that sort of an approach would work really well. So education about palliative care generally, education about this benefit specifically, and then being willing to hook people up with other programs that might meet needs that aren't covered by palliative care. It's, it's just the reality that there's going to be variation plan to plan, region to region, state to state. And I think that we're up to the challenge of managing, describing that.
There is another question. Oh, go for it.
I do think that that there has to be a really clear definition of what you consider to be a palliative care program, because there are some places that have a single nurse who talks about advanced care planning, and they call that palliative care, and it is not. So some of the things I think that Allison had put out earlier about the 24/7 availability, the credentialing of key people, the interdisciplinary nature of the team, et cetera. That's like, you got to have all of those things. If you don't have all of those things, you cannot call it palliative care. Boom. But then, you know, what Kathleen is saying is like, for those of us in palliative care, that's our world. Sometimes we think like it's everything, but it's not. And looking at the broader arsenal of services and benefits that are available to the Medicaid member, you know, those have to be leveraged in a very efficient and appropriate way. And when you need palliative care, that should be there. And palliative care can help inform too, help teach, you know, how do we understand what people need? How do we hear from them? How do we really partner with them? Those are kinds of things that even if your patient isn't on the palliative care team, the palliative care folks can help spread those kinds of skills. But we got to define it, and we have to be sticklers about it, you know?
Can't really attach a payment model without a standard definition, ultimately. And it's an important point to hold on, because that is, if we're really thinking about defining new benefits or programs inside of existing special healthcare needs or health homes, et cetera, then palliative care can't be anything to anybody or everything to everybody. It really does need to be a defined population who does actually need that interdisciplinary, integrated, team-based 24/7 support, with also a larger population or a larger general public who understands what those core principles are.
On that note, can I respectfully disagree with what Ulrich said earlier? When you were talking about defining the population, you used the word prognosis. And I guess I just put in a plea that at this point we have enough information, diagnostic categories get so specific, and there's other indicators of need in the claims. I think we should not rely on prognosis. There's plenty of people who need palliative care who are going for a cure and will be cured, and they deserve it too.
Appreciate the comment, Allison. I definitely agree with you, and see, I'm still learning a lot here too.
Wonderful. Well, thank you very much to our panelists. I think that my time has ended here, and I will turn it over to Cheryl.
Thank you. Thank you. Thank you, Tori, and our second panel for giving us a lot to think about. This is the conclusion of today's event, and we hope you've gained a good understanding of the opportunity, the unprecedented opportunity for states to work with Medicaid. I want to thank my friend and collaborator, Carmel Shakar, and her colleagues at the Petrie-Flom Center for their partnership on this project and for handling the production of this event. And I also want to thank AARP for helping to sponsor this work. In response to a question in the chat, I get to respond too here. There's a link to the video of this program. It's going to be posted on the Petrie-Flom website. So please stay tuned for further developments in this collaboration. Thank you.